screen.
All right, good morning, everybody. Welcome to the EQIP Subgroup meeting. Today should not be a crazy long meeting. Do want to give a couple quick updates, which everyone on this group should know. First of all, yesterday, finally, the critical access primary care opportunity, or the EQIP primary care, came out. So we're going to be talking about that. That would have been emailed out. You should have gotten that from Olivia. Everybody who is on this call should have gotten it yesterday afternoon, evening from Olivia. We also are sending it out to other groups as well. And I saw that the health secretary's office sent it out to the total cost of care work group. If you didn't get it, throw your email in the chat and we'll email it to you right now, all the materials for that. Second big update, which again, everybody should know, is open enrollment started on Monday. So those are a couple of the things we'll be talking about, but I just figured I'd drop them right at the very beginning so everybody knew those were the big messages to take away. This has been probably one of the busiest times for everybody involved with EQIP, running full speed, and I'll turn it over to Jessica to talk about EQIP primary care and get our meeting going this morning.
Thanks, Jean. Yeah, you're hitting the highlights, which is good because we want to make sure people are aware of those. So as Jean just mentioned, yesterday, I think late afternoon, the request for applications for the EQIP primary care did go out. We tried to hit a couple different communication streams, MedCai, the total cost of care work group, the HSCRC. I do also want to note that on the learning system, so this CRISPL/learning system EQIP PC, we have all of the documents also posted there if you need that. And then I do want to plug the deadline, which is actually the same deadline as the regular EQIP enrollment, but it is Friday, August 30th. And the request is for materials to all be sent to this equip.primarycare@maryland.gov inbox. Additionally, we will keep you posted, but there will be a Q&A hosted by HSCRC and the PMO office. I don't believe that's exactly been scheduled yet, but further information will be distributed and again posted as well. So really excited for this. Yes, go ahead, Krista, sorry.
Sorry, Jessica, can I just add one thing? I just want to make sure folks understand that all of this program is still pending CMMI approval. So that's just an important caveat. I don't know if that's getting sent out to everyone, but if folks need to understand that that is still pending CMMI approval.
Thanks, Krista.
Sure.
Okay, so let us know if there's any questions. Okay, now let's move on to EQIP enrollment. Yes, it did open on Monday and it does close on Friday, August 30th. So it's about a full 6 weeks. Just as a reminder that enrollment is done through the EQIP portal. We do have a full webinar for enrollment process, but essentially there are 2 pathways. There's a brand new entity that may have to fully onboard with CRISP. We can facilitate that. Or we have entities that are currently participating in PY3. For those entities, please note that there is not an automatic renewal of your PIS participation. However, when you log into the portal, all of your information from your NPI list to like your contact information, all of that is pre-populated to allow it to be a little bit easier this year to make edits. However, you will need to go in and select the PACES enrollment groups, since obviously that is new this year compared to the Prometheus episodes that you were participating in prior years. So please go in, do the entire enrollment process. That's essentially how you actually get in for the next year. And just as a reminder, again, does not auto renew. We do need a couple steps from you. And that can be done by either the lead care partner or the existing admin proxies for that group. One quick note. So as you guys, I think we had shared with this group, the PACES team had been working over the last couple months with specifically with lumbar episodes. They are still in the very final stages of revisions. We do expect that to be completed very soon. However, to not hold up the rest of the enrollment process, we do want to let you know that currently those lumbar episodes, lumbar decompression and lumbar fusion, do show up as unavailable. You can see them, but every entity will show a volume of 0 for right now. But once we get that information, again, we expect it hopefully very, very soon in the next week or so, you will see the volumes updated in that, and also we will add that to the episode playbook. Communication, of course, will go out with that as well. Again, the rest of the enrollment process all can be completed, and then we will email and let you know. You guys can go in and see those numbers that have been updated. So thank you for your understanding and patience with that. but we wanted to ensure none of the rest of the specialties and episodes were impacted. And finally, important resources, really want to thank MedChi and some of our other team members at CRISP here for doing a lot of work on these, but we have this posted on our website. I think they've been sent out in emails, but there's a ton of resources available for you, or if you're looking to pass along information to other interested physicians or practices. We have like a 2-pager that's a very quick overview. Obviously, we have our playbook and our transition guide, and then we have a couple other webinars that are short, under 10 minutes for some of them, about just EQIP 101, what's going on with that, the enrollment webinar, where do I click, who do I talk to, and then please remember this is also the window for the practice transformation grant. So we have a wonderful short video about an overview of that program as well. All of those there, the links will be this and when this is shared, and again, they're on, I think, multiple websites, and we'll continue to try to push those out. And then finally, we of course want to make ourselves available. So if you all feel like you want a meeting with us, essentially we can walk through what you're seeing in the enrollment portal, look at that opportunity, discuss potential definitions and sort of things like that. Please email the equip@crisphealth.org. We're happy to help facilitate those conversations. Okay, that's everything with enrollment.
And the practice transformation grant, that's done at the entity level, correct?
Correct, yes. So
And
you will
so-
see when you log in, let me see if it's actually in, no. When you log in, it's just another sort of section in the enrollment process. So each entity that wishes to apply, they complete that section within enrollment.
So just for clarification purposes, so there's no confusion, there is a Maryland Healthcare Commission practice transformation grant, which is at the practice level, which is also open right now. And that's for people who are not in EQIP yet. So if you have practices who are not in EQIP yet and need help, they can apply for that. And if they want to have information on the Maryland Healthcare Commission one, the practice transformation grant program that Jessica's referring to is a grant for EQIP entities, and you need to be enrolled in EQIP, and then you apply. And I guess this fall you'll make selections, and then people will get some help there. So if that's confusing, you can reach out to Olivia or myself, and we can help you with both of the grant opportunities. And we probably should have had somebody name one of them differently. So it would have been less confusing. But anyway.
That is true. We'll get you in the right place. Okay, so that's everything with enrollment. I'm not seeing any questions for that. So let's talk about sort of continued eligibility to savings. This was, I think, a topic that was brought up in one of our last subgroup meetings, and we wanted to sort of review everything that's going on with that. How has that impacted? Essentially, PY4 is the first year where some of these policies are really coming into play, essentially because we will have the final 2 years of data, first 2 years of final claims data. And what does that mean for people? So I guess there's a couple different probation eligibility. The easiest one to review is the probationary care partners, which is essentially at the individual care partner or NPI level. This is a little bit straightforward. So we know that our baseline is back a couple years at right now, and we have made the program in such that new practitioners can participate. However, we do put them on a probationary status during their first year of participation if they did not touch a claim in baseline. Again, this could very much be expected. It's a new grad, they've moved, it's a brand new service that you guys have created. All of those may be expected, but the intention here is because this also qualifies as an AAPM model, there are benefits for just plain participation, and we want to ensure that every care partner that is enrolled does have a relationship and impacts the episode. So if they're not in baseline, they're on probation. Again, that can be expected. There's nothing wrong with that. And in fact, you can have up to 25% of your care partners that fall into that category. However, what we look for the next year is, did they actually touch a claim? Are they now involved in the current performance year? And due to the timing of the claims, we actually base that off of the first 2 quarters. And if your probationary care partner did not touch one of those claims in the first half of the current performance year, they are not eligible to continue their participation in the next one. A little bit about timing of that. So during this enrollment period right now, from July and August, we will not know that final number. We do not know that until December, essentially right before the new performance year starts. So it is our recommendation, if these care partners want to continue to be in EQIP, to please include them in the enrollment process so they do get vetted properly by CMS. And if for some reason they fall off and do fall into that not touching a claim within the first half, we will communicate and let you guys know, because you can always drop someone from your list, or we'll let you know if you have to drop someone from your list. But we do not want to make anyone miss out on that opportunity to be vetted by CMS, which is a mandatory requirement for participation. So I hope that all makes sense. Every entity at the very start of the performance year did get a list of the individuals that were on probation, so they should be aware of that. If you need any questions or have any questions about who's on that list, send the EQIP inbox an email and we will let you all know. Okay. So the next couple slides are at the entity level. So one of the big things that I think is great about EQIP, and we wanted to ensure that's kind of embedded in the policy, is there's a lot of flexibility. The creation of these entities are not tied, as we know, to employment or location. There can be changes year over year, and we really wanted to ensure that the balance of that flexibility also takes into account some of the accountability when it comes to DIS savings and quality. So there's a couple different policies that we'll review, and then we'll review what does that mean when it comes to DIS savings. So the first one is the entity continuity policy. So essentially what this is looking at is we're looking at the consistency of the NPIs in a specific entity year over year. So we've come up with two different conditions that in our mind, the entity has changed so much, or the composition of the NPIs within that entity has changed so much that they're actually really a new entity. And those two are, if the percentage of care partners overlap between the prior year is less than 60%. So if you think about that, you've changed so much that most of the people that were in last year are not in it this year. And then the other side is if the percentage of new care partners in the current year is greater than 40%. So you've added so many people. So we'll give a couple examples in this answer below, because you can kind of see the different scenarios of how this plays out. So if we look at the first entity, and this entity sort of carries forward as is, it's considered the same entity, a continuous entity. They had 7 care partners in year 1. They had 8 care partners in year 2. And if you think about it, we don't know, are those 7 the exact same 7 in the 8? So we kind of need to look at that breakdown. So within that 8, there's 5 that were overlapping in the first year and 3 that were brand new to the entity. So when you look at that as a percentage, it does not meet either one of those criteria above. 71% of the care partners rolled over, and only 37% of the care partners are new. So it's considered the same entity, or a continuous entity. Now let's look at a couple other examples. So in the second line in entity 2 at the chart at the bottom here, in the first year, they had 16 care partners. And in the second year, they dropped to 4. So of that 4, 3 of them did carry over, or were part of that 16 in year 1, and they added 1 new care partner. So when we look at the numbers of this in that in that entity with 4 now 4 NPIs, 18, almost 19% carried over from the year before, and 25% were net new. So it does not meet the criteria of overlapping CPIs, and because it fell below 60%, and we would create that as a new entity. So in the portal, those changes may have happened, and initially it looks like, oh, entity number 100 is still entity number 100. We go through these auditing processes, and we'll let you know, oh, we'll just create a new entity ID and name, because it's changed so much that it really isn't the same entity number 100. The second 2 lines essentially walk through similar examples, one where it hits the second criteria, where you've added so many new care partners that the composition has changed so drastically. And then the final example is one where both of the instances happened. And it's a pretty good example where, again, by numbers wise, and if you look in the portal, it's tied to the same entity, but really in reality, the composition of NPIs is very different. So all that means is there's nothing new that you all need to do. Everyone go in, enroll how they need to enroll. We do these checks on the back end, and we will let you know if it is the instance where there's a new entity that are, the changes in the portal hit these and such that it defines as a new entity. We create that all on the back end. You don't need to re-enroll anything like that. It's simply just some checks and balances we do. again, the flexibility is great, but we got to ensure that it carries forward to the through our different policies. So I hope that made sense. Now the next one is the successor entity. So in such a situation where we have these new entities that were created, whether they were initiated from a brand new lead care partner that came in, or if they're a result of this continuity policy, what we're going to also look at is the relationship between these entities and any prior entities. So again, we know that these changes happen during the enrollment cycle, splitting, merging. A big multi-special entity could become 5 or 6 different more focused specialty entities. All that flexibility is encouraged and allowed, but we are looking for the relationship. So essentially, we have another threshold that looks at the percentage of care partner overlap from a single entity in the prior year. If that is greater than 60%, that entity is tagged as a successor entity to the primary entity. Again, it's simply naming wise for us, because we'll talk about that when it comes to the DIS savings policy, but essentially we're now mapping those relationships. It is new, it gets a new ID, but there is a significant tie. Again, that overlap is greater than 60% from a prior entity that existed. So you'll hear the names primary entity and successor entity, and that's where this is coming from. I will note that we did all entities that were tagged or met this criteria as a successor entity have already been informed for PY3. So if you didn't hear, you're not a successor entity, you didn't meet this criteria, all the rest of them have been aware of this. Okay, so now we have sort of the definitions and some of the policies when it comes to looking at the continuity of the composition of MPIs year over year. Now, what does that mean for DIS savings? So we'll talk about essentially 2 different ways of DIS savings and ineligibility. The first one is strictly related to the incentive payment. So if an entity generates DIS savings in a performance year, but are eligible for incentive payments in that next performance year, they do have to offset that initial DIS savings in year 1 in order to get the incentive payment. So essentially we add 1 step in that calculation to say, is there any offset that needs to happen? Pretty straightforward. Now, removal. This is one I think that there's been a lot of conversation about, and really, again, this is the first year where we've needed to actually implement this policy due to the timing of our claims and things like that. But essentially what we look at is if an EQIP entity has 2 consecutive years of DIS savings and they start in the lower 2 terciles compared to the state, they are ineligible to continue their participation and they're removed. For 1 year, they can re-enroll the next year after that. And again, the main reason, there's a lot of reasons here. I know that this is something that CMS feels strongly about in lieu of no downside savings risk. So it does kind of give us some guardrails when it comes to participation in alignment with the programmatic goals. The other way that entity can no longer be eligible to participate is in line with our catastrophic quality performance. And essentially what that looks at is if an entity is below the 20th percentile benchmark in any of the 3 quality measures for 2 consecutive years, they are ineligible. One of the things I think there's a confusion here is that baseline is simply giving you a sense of where you've started. So if you are poor in baseline, it doesn't mean you're on probation, but it's saying, hey, you're at risk. This is something you want to pay attention to in year 1. So if we look at these sort of 2 examples at the bottom, both entity 1 and entity 2 would be considered sort of at risk based off of their baseline performance. So their probation status is not applicable just based off of baseline. In the first one, that they have opportunity in the current medication area, and in the second one, they have opportunity in both current med and BMI. Now, if we look at, and I use PY2 and PY3 here as examples. So in PY2, their final numbers for this first entity, they moved out. They are above the 20th percentile on all 3. They are not on probation, and the same for the third year, for year 3. Sorry. In the second entity in PY2, they are showing some improvements in that current med, but they are still below the 20th percentile in BMI. So they would be put on probation for after year 2. and we base their final eligibility for year 4 on the first 2 quarters in year 3. So a lot of numbers, a lot of quarters there. Essentially, it has to do, again, with when the claims data is available. So in December, just prior to the start of the enrollment period, we know what the first half of the quality performance for that year is. And if someone has not moved out of probation for that time period, they would not be eligible to continue. So for people that are in that their first year is performance year 3, this is their first year of being in the program. This is no impact for performance year 4. You will continue to be eligible. Obviously, you want people to pay attention to the quality metrics and see if that's an opportunity, but no new PY3 entities essentially are going to be kicked out for PY4. Hope that helps. So it's really sort of looking at the PY1, PY2 entities. And again, all of this should be new. We've communicated it. I will say every entity in PY1 that was at risk, meaning that they performed poorly in the baseline, all moved out and above that 20th percentile. So we certainly have seen some great successes with the attention put onto those quality metrics. Okay. So we talked about these different types of entities. What does that actually mean when it comes to how we implement this policy? So we kind of categorize them into 3 different types of entity. You have a continuing entity, which holds the same EQIP ID and name as the year before. We have a new entity, which is, again, has a brand new ID for that year. And then we have a successor entity, which we just talked about, which could be created a new ID and a new EQIP ID, but has that relationship to a previous entity. So let's talk about those definitions. So continuing entity, again, they participated in the prior years. You could have one of those primary entities also be a continuing entity. They can be classified as both. Again, a brand new entity is an entity that did not participate in the prior year, and they are not classified as a successor entity. And alternatively, in a successor entity, one is someone who is brand new that year. They didn't participate the prior year, but they did meet that criteria of overlap with the single entity from the prior year. So when it comes to DIS savings and quality performance, a continuing entity, essentially, they're subject to these full DIS savings rules that we just talked about. They're kind of the easy ones. It's exactly how we intended the policies to be created and be implemented. They're sort of straightforward in that process. Now, a new entity, they're brand new, so many of these, actually not many of these, both the catastrophic quality performance and the DIS savings policy does not count for them year 1, or essentially there's not 2 consecutive years, so it's not applicable. We will note that the care partner probation is something that still is applied in that very start of any entity's first participation in the program. So they do have that. And then finally, a successor entity. So this is one where, again, we sort of balanced a little bit of that flexibility with the accountability here. And what we've said is, since you have been tagged as a successor entity, you carry forward only the most recent year of savings or DIS savings and quality performance from your primary entity. So if your primary entity had 2 years of DIS savings and you're marked as a successor entity, you are not accountable for both of those 2 first years of DIS savings. You only hold the relationship to that second year, meaning that you get sort of half a clean slate. You get to sort of start and see, does this new strategy potentially allow you to show savings now that you are different than the primary entity. And then we do have an additional note as far as that annual accountability or annual DIS savings accountability, which has to do with the offset. So if you are a successor entity and you do show savings and are eligible for an incentive payment, but your primary entity in the year prior did show DIS savings, that DIS savings is going to be distributed and used as an offset for successor entities. And we'll do that all within the relationship of the number of NPIs that are now in the successor entity. There's a lot of terminology there. I will pause and ask for questions. If you do have specific, hey, I'm, entity number, 100, what does this mean to me? We're happy to answer that specifically for your entity and show you essentially what that relationship between NPIs look like each year. I do see a hand from Victoria.
Hi, good morning. I had a question about what you just said about the successor entity with the distribution of the savings. So if, like you were saying, for the example, if a successor entity generates savings, but they had an offset from their primary entity, there will be a distribution of the savings by MPI. Is it just based off of the, I guess, the percentage of MPIs that transferred over to that successor entity? And if
Exactly.
so, okay. And in that case, is there, I guess, a scenario in which that distribution of the savings offset for their incentive payment would cancel it out and they wouldn't receive one at all?
It could. It certainly could. It depends
Okay.
on, I guess, how much their performance was in the year as a successor entity. I think it's just a little bit. It depends, but I think all of it is on. It could potentially fully cancel out. It could just bring it down a little bit. It really just depends on performance.
Okay. And a follow-up to that, so when we're talking about the savings being distributed to the successor entities, each successor entity from that primary entity is getting a proportional distribution of the savings offset, or is it just based off of the MPI count?
If you're classified as a successor entity, you would get your proportion based off of the NPI, the amount of NPIs that carried forward.
Okay. All right. Thank you.
Yeah. And if you want to like walk through exactly what those numbers look through for like your entities, just let us know, email us. We can kind of walk through what that would be.
Okay. Thank you.
And then I'll note just the asterisk at the end here. All of this is, of course, up to review. I think there's a lot of good conversation about, again, how the policy was created and then what it looks like when it's implemented. I think the goal is to encourage as much continued participation here. So that is something that's going to be monitored very closely. And we can continue to sort of have open conversations with HSCRC about that impact to ensure that people, if they can, continue to be able to participate year over year. Okay, I'm not seeing any other hands. So that was all of our prepared agenda items. I do want to note, I think I see, yes, I see Will London from Adelaide. Will had Adelaide, sorry, had reached out and wanted to have a conversation potentially about sort of connecting primary and specialty care groups that are in this value-based world. We wanted to sort of see what interest there is, if there's any middle ground that Chris can play in this. We're happy to essentially have that conversation. So Will, I'll let you have the floor and sort of talk to this group, and we can see what feedback we got.
Yeah, thank you, and thanks for allowing me the opportunity to kind of bring this this point to the group. For some background, Aledade is an ACO facilitator, and we have several dozen partner practices and CHCs spread across Maryland. And we have recently started a policy committee for those practices, both administrators and physicians, to come together and hear from the thought leaders and legislators who actually drive the conversation surrounding healthcare policy in Maryland. At our most recent meeting in June, we hosted Megan Renfrew from HSCRC, who gave us kind of a rundown of many of the programs that the state runs. And in particular, she went into detail about EQIP. And we've been following EQIP PC, but recognizing that EQIP was focused mainly on specialists, we hadn't dove too deep into the details behind that. But as she was going through the details, one of the doctors asked, he's a primary care physician, and he loves the idea of EQIP, and since he's in a value-based care relationship, he would love to be able to connect with and refer his patients to other specialists that would operate well within his value-based care alignment. But as far as we're aware, there's no tool for him to be able to find out which specialists within his area are participating in EQIP. So the question was to the group, could we create a tool, a handbook, something that would allow primary care physicians in particular, both at CHCs and in private practices, to be able to reference EQIP participating specialists so that they could refer their patients to the correct specialist within EQIP and kind of keep the value-based care mentality flowing through the entire continuum of care for patients.
Thanks, Will. And yeah, just as a little bit of background, currently we obviously don't publish everyone's participating and their contact information. I think we a little burned with that once. So we also want to be sort of mindful for you all as EQIP participants of sharing that information. But I think in general, the theme of having that collaboration of people in this value-based care space is very warranted, and we're happy to facilitate some of the connections currently, but I agree if there's a more systematic way. If many people are interested, I think it's probably worth a larger conversation to see what potentially could be at play. Or I don't know if anyone on the call currently already has sort of a network that they tap into and are aware of other people in this space. Like I said, we don't want to reinvent the wheel, but yeah, want to make those connections for people with aligned incentives and goals.
I should say, coming from the physician background, we totally understand the hesitance to make that information public, and we're not asking for any kind of, advertising of that information.
Yeah, and Will, I don't think I think like we might be willing to share the MedChi entities, but that would be a decision I'd have to talk to the care partners of each of the 10 or 11 MedChi ones, and we can certainly maybe the thing to do is if we could share your information with the care partner leads or something and see if the entities would be willing to share their names. But I want to make another point too that I would encourage you to do, and I think when you and I spoke last week or the week, whatever it was, 2 weeks ago or 3 weeks ago, I would just also encourage the primary care docs to look at what they're doing and look at the 50 or so bundles, because there might be some bundles that apply. And particularly, I would argue the 2 behavioral health bundles that we just developed, it might make sense for some of your docs to consider that, depending on what their practice is like. And primary care, you see one primary care, you've seen one primary care. So they're all a little different. But I would also encourage just to get those primary care docs to look, and Chris can run a report and see who's eligible. So maybe you and I and Jessica can have a discussion offline on an intelligent way that we can encourage voluntary participation between the people who are in the different programs to coordinate. Okay.
Yeah, that'd be great. I think we've been working on all of your suggestions that came out of our meeting the other week too, and moving forward on those. And any way that we can work to collaborate and mesh the gears a little bit better within the obvious boundaries of the program, we're happy to look into.
Yeah, we just had a bad experience. Well, and I just so everybody knows that what we do is when someone has a reasonable request, we've let them have 5 minutes to present at the meetings is what we've done. And then it gets, so that's why I think we had Medeo, which is a subsidiary of USC ACS, it's a large physician practice that is doing end of life care. We had them present for a few minutes. We had Dr. First, which is a Maryland technology company, which is working on end of life as well, present. I think we've had a couple other companies present, and we do that instead of sharing the names because we had challenges early on when the names got out. So that's the thing that we're trying to figure out. But what you're asking for sounds, I think Krista and Jessica and everybody all thinks it's a really reasonable request. We just want to make sure that we do it in a way that we don't end up creating a problem.
Yeah, absolutely. I mean, the goal of this is to ease everyone's burden a little bit, not create more problems.
Right. Okay. And then I see Victoria. And is there anything else, Will?
No, I know. I'm happy to leave my email address if anyone is looking for any further information. I'd be happy to lay out, I think, what exactly we'd like to do. So I'll drop that in the chat, and I'll look forward to connecting with Eugene and Jessica and the rest of your team at a later date, and we can brainstorm.
Okay, we have a couple questions in the chat. Jessica,
Yeah.
do you want to take the first one on the lumbar enrollment groups?
Yeah, I think actually both of them are ones that I can answer. So we don't have an exact date. I think it's just going to be another week or so. We will send out communication when it's there. Our recommendation essentially is like, do the enrollment portal as much as you can. If you're interested in lumbar, that will become available shortly, and we'll let you know. Like I said, we wanted to not halt or any of the additional processes that are going into place with this, but certainly can do that. And then I actually probably should have mentioned this, but yes, so PY2 final data, we are anticipating releasing that by the end of the month. I want to say that's Friday, July 26th. sorry, quickly pulling up my calendar. Yes, 26 is the expected release date. We are doing obviously some internal review and auditing before releasing it, since it is those final numbers. But again, that also will let you guys, we'll do some blast communication when those numbers are released. So it will be in the middle of the enrollment period, and people can certainly, hopefully have some discussions about that and its any impact to continued participation.
And how about the Q1 for this year data? When do we expect that?
So Q1, I believe, is the September timeframe is our normal timeframe for that. Most of the 6-month episodes just completed June 30th, or not even those that just started in January completed June 30th. So we do need some time for run out for things like that. So,
but we're not. Are we experiencing delays from?
No, that's our normal cycle.
I'm talking about for the end of year for PY2 because of the change situation. Is that a complicating factor?
Yeah, so it initially would have been released about a month earlier. At the end of June was our normal cycle, I believe. For Q4, it's about a month of delay. But yeah. And
so, are we going to have a month delay on the Q1? My concern about the Q1 is that if you have, like, for example, almost everybody in the MedChi entities is brand new, so that means they're not going to have any data until September. If we lose a month because of Change Healthcare, then all of a sudden they're not going to be data until October. It's really hard to fix things with only 2 months left in the performance year.
We don't anticipate that. I think we had this major delay sort of in the spring time period when obviously the big incident happened with Change, but we're really back on schedule with them. I say that obviously not knowing the future, but I think we feel confident that now that this Q4 has been done, we'll get back on our normal schedule with them. And obviously, once we're in the PACES world, we will be able to start processing some of that data ourselves, but still need to wait a fair amount for the claims lag and for the episodes to complete. So.
All right. Any other questions or comments for the good of the order? Chris, did you want to add anything? No? All right.
Oh, sorry. Nope.
Nope.
Thank you, team.
All right. Well, then, everybody have a great weekend and stay cool.
Thanks, everyone.
Thanks, everyone.